this is Handsome Nerd ASMR, back with another video. For this video, we're going to be discussing or analyzing the difference between nephritic and nephrotic syndrome. So let's begin. In order to understand the difference between nephritic or nephrotic syndrome, it is important to think about the pathophysiology, clinical features, and underlying etiologies behind these two syndromes. So, let's break down the fundamental differences. So for nephritic syndrome, the primary pathology is the inflammation of the glomeruli, and some key features will include hematuria, or red blood cells in the urine. The red blood cells will be dysmorphic in shape, and sometimes the red blood cell cast may be present. For the glomerular injury involved, it is going to be an endothelial and mesangial cell injury, which is going to trigger inflammatory response. For protein loss, it is going to be mild to moderate in nature, with less than 3.5 grams of protein lost per day. And for the presence of edema, it is going to be mild to moderate, and this is due to some salt retention. Blood pressure is often going to be elevated for nephritic syndrome, and then some urine findings in nephritic syndrome include hematuria, red blood cell casts, and mild proteinuria. For nephrotic syndrome, the primary pathology involved is podocyte damage with increased permeability, and podocytes are cells located adjacent to the glomerular basement membrane, and they are part of the filtration process. And some key features of nephrotic syndrome, or I should say the main feature, is massive proteinuria, where greater than 3.5 grams of protein are lost in the urine per day. The glomerular injury involved is the podocyte that is injured, and specifically there can be podocyte effacement. Overall, the key distinction between nephrotic syndrome and nephritic syndrome in terms of glomerular injury is that the type of injury in nephrotic syndrome is non-inflammatory, while for nephritic syndrome, the injury is going to trigger an inflammatory response. Moving on to the topic of protein loss, the loss is going to be heavy in nephrotic syndrome, with greater than 3.5 grams of protein loss per day, and then the edema is going to be severe in nephrotic syndrome due to the decreased oncotic pressure, and that is because of that loss of protein, typically involving the protein called albumin. And then the blood pressure is going to be normal or low in nephrotic syndrome, although sometimes it can be high if fluid retention occurs. And then for urine findings, the classic findings will include fatty casts that are shaped like oval fat bodies and severe proteinuria, and this applies for nephrotic syndrome. Let's talk about nephritic syndrome in greater detail. So it all begins with the immune-mediated inflammation of the glomerular capillaries. This leads to the injury to endothelial cells, mesangia, and the glomerular basement membrane. As a result of this, there's going to be infiltration of neutrophils, along with complement protein activation. As a result of this, there is going to be capillary rupture in the glomerulus, and this is going to allow the red blood cells and proteins to pass into the urine from the capillaries. And so, some clinical features to note for nephritic syndrome include hematuria, and so, as a result of this, the urine is going causes of nephritic syndrome. The most classic common cause is post-streptococcal glomerulonephritis. The resulting glomerulonephritis occurs 2 to 4 weeks after some pharyngitis infection or an impetigo. This leads to decrease in C3 complement protein and then hypercellular glomeruli. Another disease that is known to cause nephrotic syndrome is IgA nephropathy, also known as Berger disease. Some key features of this include recurrent hematuria, wet upper respiratory infections, or gastrointestinal infections. Rapidly progressive glomerulonephritis is also known to cause nephrotic syndrome, and then key features include crescent formation and aggressive course of the disease or the inflammation. Alport syndrome is also known to cause nephritic syndrome, and some key features include that it is an X-linked inheritance pattern. There's going to be hearing loss, eye problems, which ultimately stem from type 4 collagen defect, and then there's going to be membranoproliferative glomerulonephritis as another cause of nephrotic syndrome. For this inflammation, you're going to observe tram track appearance of the glomerular basement membrane, along with immune complex deposition in the glomerulus. Alright, now let's talk about nephrotic syndrome in greater detail. So, once again, pathophysiology involves non-inflammatory injury to podocytes and glomerular basement membrane. This is obviously going to result in massive protein leak. Also, there's going to be decreased onychic pressure, and fluid is going to start shifting into interstitial space, contributing to the edema. And there's also going to be increased liver protein synthesis as a way to compensate for the protein loss. This is going to lead to hyperlipidemia and lipiduria because the liver is ultimately synthesizing more cholesterol. And so, for nephrotic syndrome, patients will typically have high cholesterol levels in their blood. Some clinical features are massive proteinuria, as we talked about earlier. Remember, it has to be greater than 3.5 grams per day. There's also going to be hypoalbuminemia and severe edema. It can be generalized edema. It can also be concentrated to the periorbital areas and some other dependent areas. There is also going to be hyperlipidemia due to the increased hepatic lipoprotein production, and then lipiduria, presenting as fatty cast oval fat bodies. If you analyze the urine sample under polarized light, look for the Maltese cross-shaped objects, and that is going to indicate lipiduria. There is increased risk of thromboembolism, and that is due to the antithrombin 3 loss. And then there's going to be higher risk of infection due to the loss of immunoglobulins and complement proteins. So let's break down some common causes for nephrotic syndrome. So in children, minimal change in disease is the most common cause of nephrotic children or nephrotic syndrome. So it involves the effacement of food processes on electron microscopy. And the good news is that this disease responds well to steroids. So steroids are good treatment options for this. In adults, some common causes of nephrotic syndrome include focal segmental glomerulosclerosis, membranous nephropathy, diabetic nephropathy, amyloidosis, and systemic lupus erythematosus. So for focal segmental glomerulosclerosis, or FSGS, systemic lupus erythematosus. This is an interesting one because it can cause either a nephritic or nephrotic patterns. And then let's break down some pathologic differences. So for light microscopy, you'll see hypercellular glomeruli and possible crescent shape formation in nephritic syndrome. While for nephrotic syndrome, light microscopy appearance of the biopsy usually appears normal, or sometimes the glomerular basement membrane can be thickened. When you use immunofluorescence staining, you're going to see immune complex deposition for nephritic syndrome, and such deposition can be granular or linear in appearance. And if for nephrotic syndrome, immunofluorescence may reveal immune deposits. And then for electron microscopy, you may be able to see subendothelial or mesangial immune deposits in nephritic syndrome. While for nephrotic syndrome, there's going to be effacement of foot processes and subepithelial deposits. And this typically occurs in membranous nephropathy. One thing to note is that effacement of foot processes can be only detected in electron microscopy rather than light microscopy. Alright, so in summary, nephritic syndrome involves proteinuria, that is mild to moderate, hematuria, that is prominent, and you might see dysmorphic red blood cells and red blood cell casts. There's also going to be mild to moderate edema, and then often increased blood pressure and a decreased complement protein levels, especially in post-streptococcal glomerulonephritis and membranoproliferative glomerulonephritis. Urine sediment may reveal red blood cells and red blood cell casts, and the main pathology involved is inflammatory glomerular injury. For nephrotic syndrome, proteinuria is going to be severe and greater than 3.5 grams per day. Hematuria is going to be either rare or absent. There's going to be severe and generalized edema. Blood pressure can vary depending on some other factors, and complement levels will usually remain normal. On the other hand, urine sediment may reveal fatty casts and oval fat bodies. And then the pathology involved is non-inflammatory podocyte injury. Lastly, some clinical pearls to note are the following. For nephritic syndrome, think about inflamed glomerulus that bleeds. The main classic signs are red blood cell casts, oliguria, and hypertension. For nephrotic syndrome, think about leaky glomerulus that loses protein. And the main clinical signs will include severe edema, hypoalbuminemia, and hyperlipidemia. Alright, that is the difference between nephritic syndrome and nephrotic syndrome explained in an ASMR style.